questions? Yes.
Sorry.
Wait, let's get the mic.
This one here.
Yes,
got one
thank you.
Yeah.
So I noticed that the checks that you do during the insertion and removal, the occlusion, how do you know that there is not an interference, like a unilateral contact in one of the clasps that you might risk fracturing in?
Yeah.
So when,
The reality is these are children who never keep their mouth shut. No, they never keep their mouth shut, so I don't care. Right? Because this is just temporary. This is temporary. They've spent 8 years of their life with their mouth open. Does it matter that their bite doesn't fit? All right, so just short term, long term, of course. You've got to, when you've got your retainer, you got to check, make sure there's no interferences, that the rests aren't too long. It's mostly the rests at the back being too long. All right, you got to keep trimming them until the plunger, it's the parallel class hitting the lower 6 central fossa. If your rest sits too far into that central fossa, it'll jack them up. And they'll say, oh, come on. Yeah, so you just keep trimming it and play with it. Yeah. Yes.
For that particular dentorum screw,
Yes.
how often do you ask the parents to activate it to get, say, 1 millimeter expansion on the upper
night.
every
They
night?
do
The lower would be every other
every
night.
night. Because the lower is the smaller screw.
Oh, smaller screw. I see.
Ah,
Yeah, yeah, that's
Alright.
right.
So if you use the same screw upper and lower, you're going to have.
Oh, okay. The lower
Right,
is smaller
upper
screw.
screw is a 0.8 millimeter screw. The lower screw is a 0.35 millimeter screw. So it's the same rate, half a turn every night. Alright.
Okay.
You don't want to confuse the parent. Now, the upper you're doing every night, the lower you're doing every second night. No, actually, it's the main screw. He said he can only do 0.35 a millimeter every 8 days. So what's the maths? The
And
maths has been worked out by the screw that we've picked.
And normally I would count one activation, one turn as like 90
Yes.
degree.
It's 45.
Yeah, I can see you say one
It's always
to
half.
is 45. Oh,
Half the distance. We're doing a
Yeah.
semi-rapid on the upper.
Okay. Yeah.
All right. So it's about a mil every 8 days. On the lower, we're doing a slow expansion.
Yeah, understand. Thanks.
Yeah.
Thanks.
So these are really important points because when your technician who isn't Enrico sends you an appliance, you need to know what screw they're using and you need to know what dimension that screw opens. But because what I need to make it work is a 0.8, 0.9 screw on the top and a 0.33 or 0.35 screw down the bottom. And it's a 45-degree activation, half a turns, so that it's one full revolution every 8 days. Now, mums respond well to half a turn. Dads, you've got to take 45 degrees.
Okay.
That's how it is.
How do you handle patients?
A microphone.
How do you handle patients with separated parents?
That's one of the questions I asked. Are
Uh-huh.
you guys together?
Yeah.
Are you going to fight?
Mhm.
No, I'm serious.
No, well, you have trouble with just like, dietary maintenance with
Mm.
with kids a lot of the time, like,
Yeah. I said this only works if you stop fighting.
all right, okay.
I'm
So you
serious.
actually asked them if they're divorced or separated.
Look, I said, are you together? Right. How many nights does he spend with you and how many nights does he spend with you? Now, everyone can do this, can work, but everyone has to follow the schedule.
Okay.
Because this is a real question in a real life situation, because I don't know what the stats are, 40%. It's like a lot. So you have to sit with them and you have to sit with both of them. And it can be one in real life and one on Zoom. But they both have to be there at the presentation. Like they won't want to be in the same room, That's fine. One's on Zoom, one's here in person, or both on Zoom. Doesn't matter, so long as you speak with both of them at the same time.
You're saying for your clasp, you want a 45-degree angle. I've noticed on some, especially when you're clasping the D in a purely primary dentition, or you're clasping the 6 in a late mixed, that doesn't look that 45. Is that just how it is because a clinical client hat's short and that's what you can do? That's normal.
Which is why we want ease and not any other time, right? Because how do we get that nice click, click? Because we've got an E.
Yeah.
And the morphology of an E allows you to lock it in like a fixed appliance. You start working late or start working too early, it's not as good. So there's a sweet spot, isn't there? Like all things in life, there's a sweet spot.
And if you had just a purely primary dentition, would you consider just doing the E because it's a nicer, it's got a,
Sorry?
if you've got a purely primary dentition, would you consider clasping the E, which is at the end of the arch, or would you still use a D and...
I prefer the D. So the question is, in a pure primary dentition, which tooth do you clasp? My answer is, I prefer the concept of clasping the middle tooth so that I've got resistance points on either side.
Yeah.
So I will use the D unless it's a TP. Some Ds are like a TP. And they have zero retention. But I can figure that out by looking at the model.
Yeah, okay.
And then if I do the 6, I have to do it like a denture-free end saddle, right?
Yeah. Okay. I've got one more question. So you've so you're trying in the appliance for the first time, you're bending the clasps out of the way, and you notice that, like there's no rock on the acrylic. So you bend the clasps down, but you just can't get it back in. Like, what do you look for next?
Well, 12 years ago, I was there. It just takes time. You just keep fiddling. All right. So you think, okay, you're trying to look to see, is it sitting under the contact point? Is there a separation?
Yeah.
What's stopping it from rocking over?
Yeah.
So you start to systematically look at each point.
Yeah.
You think, is it the left distal clasp? Is it the left mesial clasp? Is it the right mesial clasp? All right. Where's it hitting? Have I got it too wide so it's hitting the tooth behind and the tooth in front? So you just got to systematically look at what's stopping each side from going in.
Yeah.
Right. Is there separation? No separation? Do I need to bend them back up a little bit? All right. So that I can fit it down again. Now, if you're sending scans, STL files, you don't need to do that test fit.
Yeah.
Because it's going to be a perfect, there's no distortion in that model, right? The computer won't let you send it as an approved if there's distortion. But you can send an alginate, which is completely distorted, and he'll pour it up and it'll look fine. But if you scan it, it won't let you send the file unless all the data's there. Yeah?
Okay. Just condensed 12.
Just a question over there.
Simon, if when you get a situation where a child is a brother
Mm,
and two things, they might distort the wire.
yes.
And also the other thing, because of the vertical height of the tooth, retention is a problem.
Yep. Yes, it is a problem. And bruxes are always like, who struggles with bruxes in normal dentistry? That's life. You just plan for more appliance repairs. Because you know, right? They're going to break anything you put in their mouth because they're broken in half their teeth. Right? Like, who puts all ceramic porcelain in a bruxer? You talk him into doing gold. Right? So you know, yep, he's a bruxer. You've bumped 20% onto your quote for repairs. But some of it is, why are they bruxing? So if you resolve that issue first, because they got the deep bite, they got the big adenoids, or they've got the soft palate that's dangling and comes up and blocks it off. So am I treating them before the ENT? No. Oh, he doesn't snore and doesn't grind anymore. Great, let's start. Primary care first.
Coffee in 5 minutes.